Welcome, and thanks for joining us for a deep dive into the fascinating and sometimes frustrating world of meniscal pathology. Think of this as our pre-op briefing. We were going through the source material you provided, a pretty comprehensive review of the indications, the techniques, and maybe most critically, the consequences of arthroscopic meniscal resection.
Yeah, this specific chapter, arthroscopic meniscal resection, it really emphasizes the massive, almost philosophical shift that's occurred in orthopedics over the last, few decades regarding this structure.
Definitely.
For a long time, meniscectomy was just seen as a quick, easy fix, sort of a mechanical problem solved. It was almost considered, functionless,
Right.
an afterthought.
Expendable.
Exactly. But now the evidence is just overwhelming. It's clear. The meniscus is absolutely crucial. It gives you lubrication, proprioception, that vital shock absorption, and maybe above all else, complex force transmission. It alleviates massive contact pressures on the articular cartilage.
Precisely. The big takeaway, the thing we have to internalize before we even, scrub in, is that shift. Moving from resection, which used to be the comfortable default, toward tissue preservation as the absolute priority. If you don't grasp that philosophical pivot, you miss the entire point of modern knee surgery, really. We need to unpack why that shift happened, review the critical and, let's be honest, often unforgiving anatomy, detail the classification system, and then drill down into the clinical and surgical decision-making process, the part that dictates when preservation simply isn't an option and we actually have to pull the trigger on resection.
So our mission today is really to distill that clinical wisdom, understand the meniscal resection procedure, analyze its critical biomechanical function, and detail the meticulous technique required when we are forced to accept that severe trade-off and perform a partial resection because the pathology is, irreparable.
Okay, let's start with the physics of the knee. Because if you don't understand the physics, you fundamentally misunderstand the long-term consequences of, picking up that shaver.
Right.
When a patient puts load through their knee, what exactly were the meniscal components doing to protect those articular surfaces?
Well, they're acting as the joint's primary load distributor and, importantly, a critical stabilizer. In a normal knee, the menisci are responsible for transmitting, an astonishing 50% of the compressive load and extension.
50%.
And up to 85% in flexion. This distribution, it's achieved through its unique microstructure. We usually focus on two main fiber types that are structurally, imperative.
Which are the real workhorses of the structure,
Yeah.
the ones doing the heavy lifting.
The primary workhorses are definitely the circumferential fibers. These run horizontally, sort of around the meniscal body. Their main job is to manage what we call hoop stresses. Think of the knee joint under load, like a wooden barrel being squeezed. As the femur presses down on the tibia, the compressive force tries to push the meniscus outward, right? Like hydrostatic pressure pushing against the staves of that barrel.
Right.
The circumferential fibers, they act like the metal bands around that barrel. They tighten and resist that outward radial expansion.
That's a great analogy. So the structural integrity of the meniscus is directly related to its ability to contain that outward force. If you cut those circumferential fibers, poof, you lose the hoop tension and the whole system fails.
Precisely. If we resect a radial tear, for example, or if the meniscus is avulsed at the root where those circumferential fibers attach, that hoop tension is just eliminated completely. Right. And without that resistance, the meniscus extrudes or gets pushed out, and the load shifts directly onto the smaller central surface area of the articular cartilage. The secondary fibers, or the radial fibers, they act like tie rods, kind of connecting the circumferential fibers, and they manage the shear stresses during rotation and gliding.
So you need both.
You need both, but lose either set, especially the circumferential ones, and you lose the whole load-bearing system. You end up with excessive focal pressure on the cartilage.
And we know this structural integrity is, doubly critical in a knee that already lacks its primary ligamentous check.
Yeah.
We're not talking about the ACL deficient knee, obviously.
Yeah.
The sources mentioned, I think it's figure 24, noting that the menisci significantly improve joint stability. They act as secondary restraints when the ACL is gone. Without that primary ligamentous control, the menisci have to pick up even more slack, becoming essential for controlling anterior translation and rotational instability.
And what's truly terrifying, really, from a long-term prognosis standpoint, is how quickly the mechanical environment degrades with even minimal tissue removal. It's not some gradual decline. It is, like you said, a cliff.
A cliff, yeah.
The literature highlights these truly startling, now classic statistics. A partial meniscectomy of only 10%, just 10% of the meniscal width, has been shown in cadaveric studies to increase contact pressures in that compartment by a staggering 65%.
65% increase from trimming just 10%. Patent number. It should be carved into the ceiling above every OR table, shouldn't it?
It really should.
It makes that analogy of trimming a crucial gasket even more relevant. You think you're just cleaning up a little frayed edge, but bam, you just disabled the whole pressure regulation system.
And, if we are forced to do a total meniscectomy, which, of course, we actively avoid, but sometimes it's unavoidable for those massive, complex tears, that pressure increase doesn't just double. It jumps to a catastrophic 235% increase over normal.
235%, wow.
Figures 2 and 23, they confirm these biomechanical realities. And these are the core justifications for why the preservation philosophy isn't just a trend, it's a mechanical imperative. Every millimeter saved is just exponentially important for long-term joint health.
And crucially, that long-term cost isn't uniform across the knee, which is a detail that I think surprises many residents. When we look at long-term outcomes, lateral meniscectomy is consistently associated with demonstrably inferior postoperative results. We're talking Lysholm scores, subjective instability, progression to arthritis.
So the question becomes, why? Why is the lateral side the grumpy neighbor in this scenario? The answer lies entirely in the underlying geometry of the tibial plateau. The medial compartment is highly conforming. The medial tibial plateau is significantly concave, right? And the medial meniscus is wider, C-shaped, nesting snugly around the medial femoral condyle. That shape gives it inherent stability.
But the lateral side, it's a different beast biomechanically.
Exactly. The lateral compartment is fundamentally less conforming. The lateral tibial plateau is flatter, more convex, and the lateral meniscus is smaller, more circular, covering a larger percentage of the articular surface relative to the medial side. So the sources show that the loss of lateral meniscal tissue, therefore, leads to a much greater degree of instability, and it concentrates the force transmission far more destructively onto the articular cartilage. This explains the increased degeneration and consistently poorer outcomes we see in studies, like those in figures 31 and 33.
So the takeaway is,
it reinforces the principle. Maintaining as much lateral meniscal tissue as possible is just absolutely essential for stability and longevity. You have less room for error on the lateral side.
this whole issue of post-resection degeneration, it isn't some modern finding, is it? It's a legacy issue. Described over 75 years ago. Let's talk about those long-term radiographic effects, the Fairbank legacy. When he described these changes back in 1948, what patterns of failure was he really establishing?
Fairbank, back in 48, he established the classic radiographic abnormalities we still look for today, long before modern imaging. Things like joint space narrowing, the obvious sign of cartilage, lost osteophyte formation, bone spurs, and that characteristic condylar squaring. Figure 11 shows it well. These findings were clear evidence of progressive, accelerated arthritis even back then.
So the cold, hard reality is that meniscectomy accelerates arthritis.
Yeah.
It is a trade-off, isn't it? We're giving the patient acute symptom relief, getting rid of that mechanical locking, but in exchange, we are guaranteeing them a faster path to chronic joint pathology.
And that reality is just hammered home by modern long-term studies. The sources mention that post-meniscectomy radiographic changes don't always correlate with poor clinical outcomes initially, maybe because the patient's just relieved of that mechanical pain.
Right. They feel better short-term.
But most long-term studies, some going out 10, 15, even 20 years, figures 12, 13, 30 cover this, they've concluded that the surgery accelerates both the onset and the severity of arthritis in the surgical knee compared to the unaffected contralateral side. The knee is trying to adapt to this fundamentally flawed new mechanical environment, and the result is wear and tear progression that's just significantly faster than normal aging.
Okay, that sets the table perfectly then. Given the certainty of these biomechanical consequences, the big question arises. Why is repair so often off the table? Why is resection still the most common meniscal procedure performed?
Yeah.
That takes us straight into the biology of the meniscus. Specifically, its, well, unforgiving vascular supply.
Right. That brings us directly to the root of the problem. Why do we have to resect so often? And the answer is blood supply, or more accurately, the lack of it. We rely heavily on the Arnottsky principle, the landmark work defining the healing potential of the meniscus.
Arnottsky and Warren's work, yeah.
Yeah.
It established that vascular supply is absolutely crucial. So walk us through the specific vascular anatomy, the supply chain of the meniscus, if you will.
Sure. The vascularization starts from the medial, lateral, and middle geniculate arteries. These vessels run along the meniscocapsular junction, and they form the premeniscal capillary network that surrounds the meniscal border. You can see it in Figure 10 and 1. This network is basically the lifeline.
But that lifeline barely reaches the center, right? Which is the heart of the problem for healing.
Exactly. The supply chain is incredibly limited. Only about 10% to maybe 30% of the meniscal borders receive direct blood supply from this capillary network. The vast majority of the meniscal tissue, the large inner portion, somewhere between 70% and 90%, is avascular.
Avascular, meaning no blood vessels.
Right. This central portion relies entirely on passive diffusion from the synovial fluid for nourishment and, basic metabolic needs.
And diffusion is great for just staying alive. But it's terrible for structural repair, isn't it? A deep tear needs granulation tissues, cytokines, growth factors. All that stuff requires a robust direct blood supply.
Correct. The lack of direct blood supply means the body just has no mechanism to mount a real repair response in that central zone. This is precisely why we use perfusion as the foundation for our surgical decision-making. We delineate the menisci into 3 concentric zones based on perfusion, like Figure 37.2 shows explicitly.
Okay, define those 3 zones for the listener. This is the primary language we use in the OR when we're talking repairability.
Okay, first, the red zone. This is the outer third, the well-perfused periphery, typically within 1 to 3 millimeters of the capsular attachment. This zone has the best chance of successful repair because of that direct blood supply.
Makes sense.
Second, the red-white zone. That's the middle third. Here, the blood supply is marginal, kind of transitional. It primarily relies on tears extending from the vascular periphery for any chance of a healing response.
Okay, and the last one.
Third, the white zone. This is the inner third, which is completely avascular, no blood vessels at all.
And this translates directly into a pretty strict surgical rule we use to decide whether to even attempt to repair.
Yeah.
What's that crucial distance we're looking at?
Clinically, we generally consider tears within 3 millimeters of the meniscosynovial junction as vascular and potentially repairable. Conversely, tears that extend greater than 5 millimeters from this junction are functionally avascular and generally irreparable. Figures 1 and 18 illustrate this.
Right.
It's this anatomical reality that most tears we actually encounter, especially the complex ones, extend deep into that white zone that forces our hand. It forces us to choose resection, as shown in Figure 37.1 for the majority of patients. We simply can't fix what the body itself can't heal.
Okay, let's shift gears slightly to classification. We can't just lump all meniscal injuries together. The pattern dictates the mechanical instability and, frankly, the ease of removal. Figure 37.3 lays out the necessary taxonomy for us.
Yeah, we classify tears based on their orientation. We have vertical tears, which are either longitudinal running parallel to those circumferential fibers, like a split along the grain.
The log split.
Right. Or radial, which run perpendicular, radiating from the inner margin outward. Then there are horizontal cleavage tears, which separate the superior and inferior surfaces. You often see those with chronic degeneration in older patients. And finally, the ones that tend to be the most symptomatic. The complex displaceable tears. These include the small unstable parrot beak tear, the simple flap tears, and of course the large classic bucket handle tear.
Which, when displaced, looks exactly like its name suggests. A large handle flopped over into the intercondylar notch. That's a true mechanical block, isn't it? That's the one that causes acute locking and usually necessitates pretty immediate intervention.
Yes, absolutely. The displacement of that bucket handle fragment is what creates those acute mechanical symptoms, preventing full range of motion. We also have to factor in chronicity, of course. Acute tears, say less than 3 weeks old, are generally more amenable to repair. The tissue quality is better, the edges haven't frayed, retracted, or degraded yet.
Makes sense. Fresher tissue heals better.
Whereas chronic and degenerative tears are far less likely to heal, even if they technically sit in the red zone. The biology just isn't there anymore.
Let's focus for a moment on the nasty relationship between meniscal injury and the ACL. It seems like if the ACL goes, the meniscus is often next in line, unfortunately.
Oh, the incidence of concomitant meniscal tears with acute ACL injury is frighteningly high. The numbers range widely, from maybe 16% up to 82% in acute ACL tears.
Wow, up to 82%.
And it climbs to a near certainty up to 96% in chronically ACL deficient knees. Figure 17 highlights this association. What's crucial for the resident to distinguish, though, is the typical pattern based on chronicity.
The geography shifts over time, correct? It's not the same meniscus that tears acutely versus chronically.
Exactly. The lateral meniscus is typically involved in acute ACL tears. It often suffers a crush injury or a longitudinal tear during that initial rotational trauma that ruptures the ACL.
That pivoting injury.
Right. Conversely, the medial meniscus tends to get involved in chronically ACL-deficient knees. This is likely due to the repeated abnormal loading, the instability, the excessive anterior tibial translation that happens over time without the ACL there to check it. The sources suggest this is essentially a fatigue failure on the medial side.
And the big clinical takeaway here, the thing we really need to emphasize, is that meniscectomy in this context is a poor prognostic factor for the entire ACL reconstruction outcome, isn't it?
Unquestionably. The overall results of ACL reconstruction are significantly worse in knees requiring meniscectomy. The loss of that secondary restraint, particularly losing the lateral meniscal support, leads to poorer kinematics down the road and a higher risk of graft failure or just earlier joint degeneration.
So that's a huge push for us to...
It's a massive push for us to attempt early, aggressive repair of acute meniscal tears, particularly when we see them with an ACL injury. We want to prevent that pathology from becoming chronic and forcing us into a biomechanically unfavorable resection later on.
Okay, so we've moved from biomechanics and anatomy into the clinic. Before we ever wheel the patient back, we have to make a clinical call. And I want to highlight one of the most common pitfalls we see, especially with younger surgeons, relying solely on advanced imaging. This is our essential diagnostic cautionary tale.
Oh, yeah. This is where we really separate the orthopedic surgeon who integrates patient care from, the doctor who just reads the film. As the sources emphasize repeatedly, MRI findings alone must never, ever guide treatment.
Say again, never.
Never. They have to correlate perfectly with the clinical history and a positive physical exam. If they don't match, you don't operate, period.
And why is that mistake so easy to make? Why do patients, and frankly, sometimes doctors, look at a scan and immediately assume, there's the problem?
Because meniscal tears are incredibly common, even in pain-free asymptomatic knees. What we're often documenting on MRI are just the signs of aging, maybe repetitive microtrauma, not necessarily the source of the patient's current symptoms.
Right. Correlation versus causation.
Exactly. The data is stunning, really. One study found 73% of asymptomatic cadaveric specimens had meniscal pathology. More relevant to the clinic, studies on asymptomatic knees show a really high prevalence. 76% of matched controls in one study had tears on MRI. And in healthy volunteers, it was something like 13% of those under 45, and a remarkable 36% of those over 45 showed tears on MRI with no knee symptoms whatsoever. Figures 4, 6, 9, 37 all point to this.
36% over 45 with asymptomatic tears. That is the crucial context, isn't it?
Yeah.
If a patient walks in with a positive MRI, but they have no mechanical symptoms, no joint line tenderness, that tear is statistically likely to be a symptomatic noise. And it's a tear we treat with reassurance, maybe some physical therapy, not a surgical shaver.
Absolutely.
So what are the key clinical correlates, the things we absolutely need to elicit on history and find on the exam that correlate with a truly symptomatic tear, one that actually requires our intervention?
Okay, we must find a convincing history of an acute injury, like a specific moment of trauma, rather than just a vague, spontaneous onset. We need definite mechanical symptoms, true locking, catching, or giving way. Pinpoint, reproducible joint line tenderness is key.
Right on the money.
Rotatory pain, and positive provocative tests. The classics, McMurray, Apley grind, and the Thessaly tests. Figure 32 reminds us of these. The Thessaly test, where the patient rotates under partial weight bearing, that one's particularly effective at reproducing the dynamic shear forces that a torn meniscus often causes.
Yeah, it really loads it up.
So if you don't have this clinical triad, the right history, the right exam findings, and the right symptoms, your surgical indication is highly questionable, regardless of what the MRI shows.
Okay, let's discuss the management spectrum then, starting with non-operative treatment, which remains the default starting point for any non-acute, non-locking tear, right?
Yeah, absolutely. Many tears, particularly those degenerative or horizontal cleavage types, become entirely asymptomatic with good conservative management. The treatment usually includes activity modification, a focused course of physical therapy centered on muscular stabilization and non-impact strengthening, like Figure 36 suggests.
Makes sense. Build up the support structure.
Right. Surgery is only indicated and this is a non-negotiable step, when non-operative measures fail to resolve those mechanical symptoms.
And even when we decide surgery is necessary, the sources remind us the final choice between repair and resection is often made intraoperatively, only after we get the arthroscopic probe on the tissue itself.
Yeah, you have to see it and feel it.
However, we do have a clear set of criteria for attempting repair. Remind us of the key anatomical and size indications where we lean towards preservation.
Okay, generally we lean toward repair for fresh longitudinal tears located safely in that red zone. Tears between, say, 1 and 4 centimeters in length. Meniscocapsular junction tears, those are usually good candidates. And certain radial tears if they extend significantly into the vascular red zone. Figure 21 gives a good summary.
And everything else.
Pretty much anything else, especially if it's complex, frayed, or entirely within the avascular white zone, it's probably destined for resection. And we also have to be realistic about tissue quality, right? Chronic tears often have these frayed, shrunken margins that just won't hold a suture reliably.
Beyond the tear characteristics themselves, we have to consider patient-related factors, the biological variables that can really tilt the balance towards success or failure for repair.
That's right. Patient age and activity level matter dramatically. Young athletes generally have a significantly higher success rate with meniscal repair procedures.
Stands to reason. Better biology.
Yeah. Conversely, rehabilitation compliance is a major factor we absolutely must discuss preoperatively. Partial meniscectomy is, frankly, a breeze post-op. Essentially no restrictions other than pain.
Right.
While repair requires a really stringent protected protocol, often 4 to 6 weeks of protected weight bearing, sometimes longer. If a patient is likely to be non-compliant, maybe resection is actually the safer choice to avoid repair failure.
That's a tough conversation, but a necessary one. And let's not ignore the increasing prevalence of obesity. How does elevated body mass index, BMI, play into the equation for resection success?
Yeah. Elevated BMI, typically defined as over 30, it leads to demonstrably inferior resection outcomes compared to normal BMI counterparts. Figures 14 and 31 touch on this. And it isn't just because the knee is loaded more heavily, although that's part of it.
What else is going on?
It's often because the elevated BMI is already associated with concurrent arthritis or other obesity-related pathology in the knee. So we have to counsel these patients preoperatively about the difference in expected outcome. They might be starting from a lower baseline of joint health and living in a higher mechanical load environment. Their ceiling for improvement might just be lower.
Okay, now here is where the literature really pushed back against old habits, didn't it? Leading to a revolution, almost, in how we practice.
Yeah.
The degenerative tear dilemma.
Yeah.
This has been the subject of massive high-level research.
Oh, this is absolutely crucial. A must-know for anyone treating knees. The seminal research by Savonin and colleagues, a highly respected randomized controlled trial, or RCT figures 31, 34 reference it, demonstrated conclusively that patients with degenerative medial meniscus tears without coexisting established osteoarthritis.
So just the tear, no significant arthritis yet.
Right. Those patients do not benefit from arthroscopic meniscectomy over sham surgery or just rehabilitation alone. In essence, for these degenerative tears, we are not doing them a favor by going in and cleaning up the frayed edges. We're exposing them to the risks of surgery without a demonstrable functional benefit.
That's a huge indictment of the procedure when used for non-mechanical degenerative symptoms, isn't it? And what if they do have coexisting osteoarthritis? Does surgery at least help them more than just rehab alone in that case?
Unfortunately, no. Other high-quality studies, like those mentioned in figures 19, 20, 27, found no significant difference in outcomes between patients undergoing surgery plus rehabilitation versus those who just underwent rehabilitation alone when coexisting osteoarthritis was present.
So the arthritis is the main driver of symptoms then?
It seems so. If the knee is already arthritic, the meniscus tear may simply be an incidental finding or maybe just a scapegoat for the primary joint pain. Operating on the meniscus in that setting doesn't appear to improve long-term function or pain, compared to just good conservative management.
We also need to define what significant OA means here, because it dictates the criteria, for instance, for attempting a root repair. We often rely on the Outerbridge classification for cartilage damage, right?
Yeah, exactly. When we're discussing patients for potential root repair, we often strictly exclude those with Outerbridge grade 3 or higher cartilage damage. Grade 3 signifies severe fraying and fissuring extending deep into the cartilage layers, often over 50% depth.
And grade 4?
Grade 4 is complete full-thickness cartilage loss with exposed bone. So if you have grade 3 or 4 OA, the degenerative process is likely already too advanced to justify the high-risk, high-recovery protocol of a meniscal root repair. It pushes us back towards simple resection if mechanical symptoms warrant it, or just non-operative treatment if the symptoms are minimal.
Which brings us neatly to the real world of orthopedic practice. I want to humorously note the practical importance of this topic for anyone listening who's maybe studying for boards.
Yeah.
Arthroscopic meniscal resection, CPT code 29881, and those medial lateral meniscal tear ICD codes, 836.0, 836.1, they consistently top the list for the Part 2 orthopedic certification exam case submissions. Figure 16 and 26 mention this. You will see this, you will be tested on it, and you absolutely must know the proper indications and technique. Because despite all the shifts toward preservation and non-op management, it remains one of the most common procedures we perform.
No question about it, you got to know your meniscus.
Okay, we've made the call. Surgery is necessary, non-op has failed, and intraoperatively, we've determined the tear is irreparable. Now we are scrubbed in, scopes in the joint, ready to proceed. Let's review the surgical goals as outlined by Metcalf and colleagues referenced in Figure 26. Think of these as the 7 commandments of partial meniscectomy that should guide every move we make with the shaver and punch.
Right, Metcalf's checklist. It provides the essential steps for achieving a stable meniscal rim while preserving the maximum amount of functional tissue. So, first, meticulously identify the full extent of the tear and confirm, using the probe, that it is truly irreparable. You need thorough probing.
Can't skip that step.
Second, the core goal. Resect all mobile fragments, specifically those portions that you can pull past the inner margin of the meniscus into the center of the joint. If it's mobile and displacing, it's likely causing symptoms and it needs to go.
Makes sense. Get rid of the unstable bits.
Third, use your instruments, the shaver or punch, to smooth the remaining meniscal rim. You want to remove any sharp edges or sudden changes in contour that might act as a stress riser for future tearing.
Okay.
Fourth, and this is important, the surgeon needs to remember that a perfectly mathematically smooth rim isn't actually necessary. The meniscus is proven to undergo biological remodeling over time. We don't want the resident spending, 15 extra minutes obsessively smoothing the rim.
And potentially scuffing the cartilage in the process.
Exactly, when that time could be causing iatrogenic damage. Fifth, repeatedly use the probe. That's your primary intraoperative diagnostic tool. Use it to assess the mobility and the quality of the remaining meniscal rim. Stability is the ultimate metric here. Figures 37.6 and 37.7 show good probing technique.
Keep checking your work.
Sixth, protect the meniscocapsular junction and the peripheral rim at all costs. That outer 3mm to 5mm is absolutely vital for preserving the load transmission properties, those critical circumferential fibers we talked about earlier.
Don't violate the periphery.
And seventh, for efficiency and good tissue handling, use both manual instruments like biters or basket punches for controlled resection and motorized instruments, shavers, for the final debris removal and smoothing. Figure 37.0 illustrates the tools.
Good point about using both. And I always emphasize to the residents, if you are uncertain, truly uncertain, about the stability of a remaining segment, what's the rule?
In uncertain situations, the advice is crystal clear. Leave more rather than less intact meniscal rim. The goal is always to avoid a segmental resection, which the source notes essentially results in the same biomechanical failure you see with the total meniscectomy. Controlled, conservative resection is key.
Okay, let's talk setup. It's usually an outpatient procedure, standard supine positioning. Tell me about using the lateral post and the assistant's crucial role in getting visualization.
Yeah, standard setup. Supine, legs secured in a leg holder, usually with a lateral post placed just proximal to the joint line. This post is used to apply controlled valgus stress, which helps open up the medial compartment, giving you better visualization and access, especially posteriorly.
Critical for seeing the back.
Absolutely. And the assistant's role in applying the appropriate degrees of flexion, extension, varus, and valgus is critical for the surgeon's ability to see and work effectively.
But there's a major risk here if the assistant gets a bit overzealous, right?
Absolutely. We have to be extremely vigilant to prevent iatrogenic injury. Overly aggressive force from the assistant can definitely cause damage to the collateral ligaments, particularly the MCL with excessive valgus force. The force has to be controlled, fluid, and intermittent, not just cranking on it constantly.
Good reminder. Portal selection and visualization efficiency also matter, especially thinking about optimizing recovery afterwards.
Right. Most meniscal work can be done perfectly well with a standard 30-degree arthroscope, though some surgeons might use a 70-degree scope specifically to enhance visualization of those far posterior corners, especially on the medial side.
And technique-wise?
We generally favor the two-portal technique, typically anteromedial and anterolateral. The sources, referencing figure 35, suggest that this two-portal technique allows for an earlier return of quadriceps strength and function, and maybe a faster return to work compared to using three portals, likely just due to being less invasive overall. And of course, we have to be systematic in our evaluation, like figure 37.5 shows, to avoid missing any hidden pathology.
The posterior horns, the corners as we call them, they're notorious for hiding unstable fragments, aren't they? Especially the medial side, which is inherently tighter. Which specific maneuver must you ensure you get every single time to evaluate that posterior medial corner?
You absolutely must obtain the Gilchrist view. That's figure 37.8. This view requires pushing the scope far posterior, often kind of tucking it under the medial femoral condyle, to really assess the meniscocapsular attachment of the posterior horn of the medial meniscus.
Why is that view so critical?
It's crucial because this area, lying tight between the PCL and the medial femoral condyle, is just a common hiding place for a flipped segment of the meniscus, a hidden flap, or a residual fragment that can be easily missed and mistakenly left behind. Figure 37.9 shows what that can look like. Failure to resect that hidden piece can lead to persistent mechanical symptoms.
You gotta look around the corner.
Yeah.
And instrument choice is often dictated by location and the profile you need, right?
Yeah. Generally, most medial meniscal resection is carried out with an upbiter or maybe a curved basket punch. The curvature helps navigate that tight medial space and approach the tear from below without scraping the femoral condyle.
Makes sense.
Whereas lateral meniscal resection often uses a straight biter or punch, because the compartment is generally wider and the curvature of the instruments isn't quite as critical over there.
Okay, let's get into the mechanics of managing the most massive tear we often see needing resection, the displaced bucket handle lesion. Assuming it's irreparable, we have to resect it efficiently and safely.
Right. Bucket handle tears, shown well in figure 37.12, they require a methodical resection. If we've deemed it irreparable, the most efficient method usually involves using an arthroscopic scissor, or sometimes a knife, to detach the segment. We typically detach the posterior limb first.
Why posterior first?
Because the low profile of the scissor often aids access to that tight posterior area without causing iatrogenic damage to the articular cartilage or the PCL back there. It's just easier to get the tip in safely.
Okay, posterior limb detached. Then what? You've got this big, free-floating C-shaped segment just attached anteriorly.
Right. Then we perform a near-complete detachment of the anterior limb. The final step, once the segment is almost entirely free, is to grab the torn segment firmly with a strong grasper, confirm it's free, and then complete the detachment by applying a controlled twisting motion as you pull the remnant out of the portal. Figure 37.13 illustrates that removal.
And sometimes it's a big piece.
Yeah. The source notes that depending on the segment size, you might need portal enlargement, either the anteromedial or anterolateral, to extract that large, dense piece without shredding the portal or risking chondral injury on the way out. Once it's removed, then you go back in with the shaver and punch to smooth the residual edge, sticking strictly to Metcalfe's goals, like we see in figure 37.9.
Okay, now for one of the most difficult and, frankly, biomechanically damaging problems we face, posterior root tears. Often treated with repair now, thankfully, but sometimes still requiring resection. Why are these so biomechanically devastating?
Oh, they are exceedingly serious injuries because they effectively eliminate that circumferential hoop tension immediately. Posterior root tears of both the medial and lateral meniscus, basically avulsions right off the tibial insertion, are really difficult to manage. Figure 37.11 shows the pathology.
And there's a radiographic sign often linked to them?
Yes. The sources emphasize the strong link between posteromedial root avulsions and the finding of 3 millimeters or more of meniscal extrusion outside the joint capsule on imaging, usually MRI. That 3 millimeters of extrusion is directly linked to substantial, demonstrable articular cartilage loss and osteophyte formation down the line. It essentially confirms that this type of tear functionally mimics a total meniscectomy from day one.
Just catastrophic consequences, which is why repair is becoming the standard of care, right? But when do we still have to bail on repair and just resect the unstable root segment?
Repair is definitely preferred now, usually using transtibial tunnels and suture fixation to pull it back down. However, resection is still sometimes necessary for patients who don't meet the pretty strict criteria for repair. Typically age older than 50, maybe 55. Evidence of significant pre-existing OA, that outer bridge grade 3 or higher, or significant joint space narrowing we talked about, or significant malalignment.
So if the joint's already worn out.
Right. If the articular cartilage is already significantly damaged or the patient is older and perhaps less likely to heal or comply with the rehab, the risk-benefit calculation shifts heavily back towards simple resection of the mobile fragment. Just relieve the acute mechanical symptoms, even though we know the long-term prognosis for that compartment is guarded.
And a quick technical pearl for the lateral root tear. It can sometimes be obscured by the tibial spines, especially in a tight compartment.
Yeah, accessing the posterior horn of the lateral meniscus can sometimes be tricky because of the tibial spines. This often requires inverting the instrument, say, using the biter upside down, to get the angle you need to clear the spines. Additionally, if you happen to be performing a simultaneous ACL reconstruction, completing a notchplasty before you address the meniscus can really aid overall access to that lateral meniscus root area. It just provides crucial extra maneuverability.
Good tip. Ultimately, the overall principle of meniscal resection, it must always be adhered to, shouldn't it? Remove only the torn, unstable tissue, maintain a stable, viable peripheral rim, and avoid iatrogenic injury to the surrounding intact meniscus and, critically, the articular cartilage. Fauci's 37.1i sums it up visually. Meticulous technique is really the only way to minimize the long-term cost we inevitably impose on the joint.
Couldn't agree more. Precision matters.
Okay, let's wrap up our briefing by discussing the expected postoperative course, and maybe more importantly, what truly determines success years down the line. Arthroscopic meniscectomy is typically an outpatient procedure, generally very low risk, but we must always counsel patients on potential, albeit rare, complications.
Absolutely. The general complications are the ones we'd expect from pretty much any arthroscopy. Infection, bleeding, maybe neurologic injury, especially involving the common peroneal nerve laterally, so careful portal placement is key DVT, pulmonary embolism, and very rarely compartment syndrome.
And are there specific patient groups we worry about more?
Yeah, we definitely need to review patients who have an increased baseline risk for adverse events. Things like an ASA classification greater than 3, signifying severe systemic disease, uncontrolled diabetes is a big one, or significant pulmonary disease. Figure 3 highlights some of these risk factors. These patients require extra caution and often careful optimization before we even consider surgery.
Okay, what about risks specific to the meniscal procedure itself? Not the general surgical risks, but things related to trimming the meniscus.
Those risks really center entirely around technical precision, like we've been saying. They include iatrogenic damage to the articular cartilage, nicking it with instruments, collateral ligament damage, usually from positioning stress, and the risks of performing either an inadequate resection, leaving unstable fragments behind that lead to persistent pain, or, conversely, an over-resection, which results in unnecessary loss of functional tissue and just accelerates that OA process we're trying to minimize.
Right. Balance is key. On the optimistic side, recovery is generally pretty swift, isn't it? The low compliance nature of the post-op care is often why patients, and sometimes surgeons, prefer it over the long rehab of a repair.
It is usually swift, yeah. The rehabilitation focus is typically just a home program emphasizing immediate range of motion and non-impact strengthening. Studies show that a large majority, something like 82% of patients, can expect to return to sedentary work within just 1 week.
1 week? That's fast.
And only a tiny minority, around 4% of patients, report any knee-related activity restriction at 20 weeks post-op. Figure 25 gives those numbers. The general rule is essentially no restrictions post-resection other than those mediated by pain and swelling. Return to sport happens once strength, confidence, and agility are fully regained, usually within a few months depending on the sport and the individual.
Okay, here's where it gets really interesting, though, in my opinion. And it speaks to the future of our practice, perhaps. Given the certainty that we have accelerated the OA process to some degree, recent research is focusing intensely on the kinematic differences in knees that have undergone partial meniscectomies. Figure 8 touches on this. We're essentially trying to figure out how to train the body to compensate for the mechanical stability we've surgically removed.
Yeah, it's trying to mitigate the inevitable, right?
Yeah.
Using biology and training to overcome the altered physics. The research is specifically looking at how the removal of meniscus tissue alters the complex motion of the tibiofemoral joint and the resulting gait patterns.
So what are they studying specifically?
They're studying muscular activation parameters, different strength training regimens, trying to see if we can optimize rehabilitation. Essentially, can we train the muscles, the quads, the hamstrings, the hip stabilizers, to handle the load distribution and provide the dynamic stabilization that the meniscus used to manage? Can we mechanically offload the damaged compartment through learned muscle control?
Fascinating area. Okay, now let's synthesize the prognostic factors. When you look at the 12-year, 15-year follow-up data, what 2 or 3 factors emerge as the absolute most critical determinants of whether a patient progresses rapidly to painful OA versus achieving a relatively successful long-term outcome after resection?
The list is pretty clear from the literature, and it really begins with biomechanical integrity. Maintaining that peripheral rim is absolutely critical for load transmission and preserving that hoop tension we keep coming back to.
Hoop tension again.
We know that radial tears, especially those at the posterior roots, are so devastating precisely because they eliminate that hoop tension, altering tibiofemoral contact mechanics in a way that's very similar to a total meniscectomy.
So the amount of tissue removed is clearly paramount then.
Yes. Figure 10 confirms this directly. The amount of meniscal tissue removed is a critical determinant of long-term outcome. Patients who had less than 50% of their meniscal rim remaining showed significantly worse radiographic changes at 12 years compared to those who had more than 50% remaining.
That really reinforces the surgeon's objective, doesn't it? Controlled resection is paramount. Every stable piece we leave behind is a win for the patient's future joint health.
Exactly. And location of the resection matters too. Is there a particularly vulnerable area we should be even more careful about?
Yes. The data suggests that tears resected posterior to the mid-coronal plane carry a worse prognosis. This is thought to be due to the resultant increase in tibial rotation that occurs in that area after resection, which causes higher peak contact pressures and theoretically increases the risk of OA progression over time. The geometry just demands we be even more conservative, if possible, in the posterior 2/3 of the meniscus.
Okay, important point. Finally, let's revisit the pre-existing joint health, which we touched on earlier regarding the outer bridge classification and repair criteria.
Right. How predictive is the baseline cartilage status?
It seems the degree of underlying OA at the time of meniscectomy is perhaps the single best predictor of a poor long-term outcome. Increased outer bridge cartilage scores, indicating more significant OA was already present at the time of surgery, are directly correlated with poorer physical results 12 years later.
So, if the joint is already failing significantly,
the meniscectomy might provide some temporary mechanical relief, but it simply accelerates the inevitable decline. And as we noted earlier, patients with ACL-deficient knees, or those who required a meniscectomy during their ACL reconstruction, they consistently yield worse long-term outcomes than patients who had the procedure done in an otherwise stable knee. The baseline stability matters hugely. Hashtag outro.
So, resident, looking at the entire picture here, the modern shift toward preservation repair whenever possible, and even when indicated thinking about transplantation, it seems entirely justified by the, well, catastrophic biomechanical consequences we impose during resection. But when we have to resect, careful, measured technique, meticulously preserving that peripheral rim, smoothing the edges appropriately, is absolutely paramount to minimizing long-term fallout for the patient. Wouldn't you agree?
Precisely. I think the core conclusion remains. Most tears we see are unfortunately irreparable because of their vascularity or their size or their pattern, necessitating partial resection. But the success hinges entirely on proper patient selection, especially rigorous adherence to those Sivonin findings, avoiding surgery for purely degenerative tears without mechanical symptoms, particularly with underlying OA.
Right. Choose the right patient, first and foremost.
Then, meticulous technique, figures 37.1 through 37.14 really are our surgical guide for doing it correctly. And finally, setting realistic expectations based on concurrent pathology like OA or an ACL deficiency. We absolutely must counsel patients that we're often trading their immediate mechanical symptoms for potentially accelerated OA later on. It's a pact we make.
A necessary pact sometimes,
Yeah.
But one we need to be upfront about. So what does this all mean for you, the listener? Hopefully you now have the language, the mechanical context, and the critical research background to understand why a seemingly simple knee scope, that quick 15-minute CPT 29881 procedure, is actually a profound, permanent biomechanical trade-off. It's governed by the precise boundaries of those red, white, and avascular zones. And here is a provocative final thought for you to mull over. We know meniscectomy accelerates arthritis. We know that knee kinematics are irreversibly affected. Given that we still perform many partial meniscectomies, the research, as we discussed, is now focusing almost exclusively on rehabilitation protocols to try and counteract these kinematic differences we've induced.
Could optimizing muscular activation and strength parameters post-resection literally training the patient's own musculature to stabilize the joint and distribute the load in a way that the missing meniscus no longer can. Could that be the critical missing link? Could it be the only way we can truly hope to slow down the inevitable progression of OA in these patients? If we can't save the tissue itself, can we maybe save the joint with smarter, better trained muscles? Something to mull over next time you see a patient with a trimmed meniscus.